Hello everyone. Today I want to talk to you about how we might use imaging tools that are readily available in the clinic to monitor patients with advanced prostate cancer. These are my disclosures. Imaging clearly plays a key role in the management of patients with metastatic disease. In fact, it can be a complete game changer. So for example, in the setting of biochemical recurrence, the presence of metastatic disease completely excludes the possibility of salvage therapy, particularly if the metastatic disease is extensive. And here is some of the evidence that I put together about what imaging can tell us about the metastatic state. So for example, we now have very good evidence to show that high volume metastatic disease patients have worse survival than lower volume of disease, and this is as determined by imaging, and it doesn't matter which imaging test you use, this has been shown. Furthermore, we know that the dominant location of the metastatic disease is also highly prognostic. So for example, patients with nodes do better than bones, who do better than patients with lung disease or liver disease. And here you can see a recent paper that was published by Halabi in JCO, which shows the poorer survival of patients with liver disease, who are these patients here, compared to those patients with lymph nodal metastases alone. So the question we really have to ask ourselves is the current tool set that we have fit for purpose? Well, I would contend that the tool sets that we have are rather limited. So for example, we are unable to identify patients who have metastatic disease with any great confidence, as a result of which we have late detection of disease. So people we think are non-metastatic, in fact, are metastatic. People we think have few metastases have a lot of metastases. And I just wanted to show you an example of this. Here is a patient who has been looked at using conventional imaging with bone scans. Is this good enough to assign the state of oligometastatic disease? We can see 3 deposits here in red. But is this good enough to say oligometastatic disease? Well, if you do a whole body MRI scan, what you notice is that in fact there are 6 or 7 metastases pointed out by these arrows on this whole body MRI scan. We'll talk about this particular type of scanning approach in a few minutes. But how do we know that these are metastases? Well, the whole body MRI approach allows you to interrogate each one of these lesions. Here are the morphological images of one of the lesions shown on the T2, the T1, the axial T2, and on the diffusion sequences, confirming that this lesion is in fact a metastasis, confirmed by the CT scan that was performed at the same time. So is this poor performance of bone scans compared to modern imaging with MRI scans, for example, an exception or the rule? Well, here is a meta-analysis that was published a couple of years ago, showing that the performance of planar bone scans in particular are not nearly as good as the modern imaging techniques with fluorocholine PET and MRI. And this is shown, I think, quite nicely on this ROC plot, where we can see the scattered performance of bone scans compared to the consistent high performance of MRI scans and the high performance of the fluorocholine PET scans, suggesting that in fact in the modern era one might want to be thinking about not using bone scans that often. One of the other problems with bone scans is that we are unable to identify who is not benefiting from treatment early after starting treatment, which means that we fail to progress patients to standard therapies so they can become eligible for clinical trials or the newer types of treatment. So I just wanted to show you an example of that. Here is a patient with metastatic castrate-resistant prostate cancer who was being treated with enzalutamide. Now here is the PSA level. We can see then on the whole body MRI scan there are retroperitoneal lymph nodes. The bone scan is negative. The patient gets treated with 12 weeks of enzalutamide. We can see that there's been some resolution of the nodal disease. No abnormalities are detected on the bone scan, which is what we would expect. But at week 25, the whole body MRI scan shows you a new lesion. You can see nothing on the bone scan. Now, we can confirm that this new lesion is metastatic by corresponding axial images through that area. We have comparisons with the prior scans. We can confirm that this is a new lesion, therefore this is a metastatic deposit. But the bone scan is the standard of care, so the patient then continues to be treated. And here we are 12 weeks later at week 37, when we can see 5 new bone lesions on the whole body MRI scan and 2 lesions on the bone scan. So is this progression? The answer to that is no, because the patient we need to confirm the presence of these 2 lesions, and the patient then continues and receives more treatment until the 2 lesions that we had seen previously are confirmed, and in addition we now see the emergence of new lesions. Now, the interesting thing is that week 49 is the date at which we confirmed progression, whereas progression actually occurred at week 25. So there was a delay of 25 weeks before a treatment change could be instituted. And this is the fundamental problem of using bone scans as a method of assessing therapy response. Now, is there anything we can do about this? Of course there is. We now possess many more tools than we used to for assessing bone marrow disease, and some of them are laid out over here, many of which of course are not readily available in clinical practice. One that is available is CT scans. We know that there are several morphological patterns that have been described in the literature, and we know that these imaging appearances are biologically meaningful in terms of the mechanisms of the disease underlying these. And here I've summarized that biology. So if you have a purely sclerotic metastasis such as this, we know that this is the product of upregulation of the Wnt pathway and increased osteoblastic differentiation and function, which leads to the emergence of the sclerotic metastases that are so typical of prostate cancer. Whereas if you see lytic lesions, and here is a nice example of lytic lesions, this is due to the expression of inhibitors of the Wnt pathway, such as DKK1, which leads to increased osteoblastic activation and then the emergence of lytic lesions. So the pattern tells us something about the biology. We also know that classically CT scans are useful to sort out the false positives of bone scans. And here is an example of a bone scan in a patient's spine. We can see that this degenerative change explains the abnormal bone scan that we observe on the planar bone scan. So CT scans can help sort out the false positives of bone scans, and that's why it's employed with SPECT CT scans. One of the other things that you need to realize is that we do not confidently pick up all sites of metastatic disease with CT scans, particularly in the bones, and we can underestimate the amount of bone disease that is actually present, particularly of the infiltrative type. And here's a gross example of extensive infiltrative disease affecting every vertebral body, and the gross underestimation of infiltrative bone disease on a CT scans. Finally, with CT scans, osteosclerotic progression and osteosclerotic response can be difficult to distinguish. Let me just illustrate this. So here's a patient with multiple bone scans over a prolonged period of time in a patient who was receiving enzalutamide. We can see, in fact, the common flare phenomenon where the first bone scan shows the presence of new lesions, which can sometimes cause a problem, but you can see that over time treatment continues and these lesions in fact fade away. And if you look at the total of burden of disease, you can see that the patient has been responding. If you then look at this particular patient and a look at the CT scans of this particular patient, you can see the emergence of a new lesion, well defined, looks like ivory bone, and in fact this is something called sclerotic response, although it looks like a new lesion. Now compare that to this appearance, which is sclerotic progression. So here you can look at the PSA. You can see the PSA has increased when the patient is being treated with abiraterone. Here is the spine straightened out in the coronal, and in the sagittal plane you can see increasing bone sclerosis, but this is due to progression. So not all sclerosis is healing, as I showed you before. So what other techniques can you use? MRI scans enable us to look at different constituents of the bone marrow and combines morphological and functional imaging assessments to be able to get an idea of what's happening in the bone marrow. One of the important things to remember is that whole body MRI scans can now be done within about half an hour for disease detection protocols, and if you want to do response assessment protocols, that can be done on the most modern of machines within 45 minutes. So here's a typical detection protocol in somebody who had a rising PSA, and you can see this metastasis on the morphological sequences. Here is a lesion in the liver, and this is the diffusion sequence showing metastatic nodal disease. You can see the bone metastases also. Comprehensive protocols, as I said, take about 45 minutes and combine axial images in addition. So here is another patient, again with metastatic bone disease, and if we want to look at a particular area, we can acquire axial images through that area. Here are some of the signs one might be able to look at for progression. So the emergence of focal or diffuse disease would be a sign of disease progression. And here is an example of a patient who is developing progression despite a reduction in the PSA. So you can see new lesions emerging. The previously noted lesion is larger, and if you look at the whole body diffusion scan, again you can see very many more metastatic deposits, and this area here in fact represents an area of adrenal hyperplasia because the patient is on enzalutamide, and response is the other way around, so you expect abnormalities to decrease or completely disappear if one were to look at response criteria. Now, as it turns out, there are problems with looking at response and the disappearance of lesions. So, for example, here's a patient who's clearly getting better with docetaxel. You can see the PSA goes down and stays down. The question is, you can see here that this lesion becomes a bit smaller but then becomes stuck. And what do we do about the response of this lesion? Similarly, you can see the emergence of new lesions, in virgin bone marrow, but then with response, and you can see the PSA came down with carboxytaxel on this occasion. Again, you have these scars. And how does one deal with that with morphological imaging? Well, the way to deal with that is to use something called diffusion imaging, which is what I've already shown you. And diffusion imaging on the same patient is much better able to cope with these scars that morphological imaging is not able to deal with. So between here and here, you can see the patient progresses. The patient receives radiotherapy for these two metastases. No other treatment was given. Clearly the patient has developed progression. Despite that, you can see new lesions and enlargement of previously noted disease, also in the emergence of new disease. And you can see with 4 cycles and 10 cycles of docetaxel, you can see this response very nicely. And then when the patient relapses, the emergence of new lesions, and then after 8 cycles of carboxytaxel, the fading of these lesions. So what biological property are we looking at when we do diffusion imaging? Well, we're looking at cell kill, essentially. So the signal intensity reduction of the nodal disease and of the bone disease between these two examinations on docetaxel is a result of the cell kill. The cell kill results in increased water mobility that coincides with a reduction in cellular density, and this is what we see here in the cartoon. And we see the same thing here with a shift of the histogram to the right. This is the apparent diffusion coefficient map, value histograms, which move to the right. In other words, the water is moving more. So here's the advantage of MRI. It combines morphological imaging with functional imaging, be it diffusion imaging, be it the evaluation of cellular water motion or the cellular fat fraction, to be able to know what's happening in the bone marrow. So let's reflect on this and talk about what technique we should be using in practice for metastasis detection. Well, I think we can all be fairly confident and say that planar bone scans no longer should be the standard of care. We should be thinking about improving bone scans, and SPECT CT scans may be a way to go, but we may be thinking now about replacing the bone scan completely with other techniques such as whole body MRI scans, which I've already shown you, but you may also want to combine it with choline PET scans, or if you just wanted to look at a better bone scan, then perhaps a sodium fluoride PET scan could be undertaken. And just to show you an example of what a whole body MRI scan and a choline scan looks like. So here, for example, is a patient whose PSA is increasing. This whole body MRI scan was read negative. This is a sebaceous cyst on the back. On the choline PET scan, you can see 2 lesions. And when we look at the axial images through that area on the choline PET scan, we can see the lesion in the left internal iliac region. Now, as it turns out, it was visible on the MRI scan, but prospectively it wasn't called, so we have to call this negative, although you can see that there's a clear asymmetry. So in fact, choline is better for soft tissue disease, and it turns out that the MRI is probably better for bone disease. So here is a lesion in a rib in somebody whose PSA is increasing. Very difficult to see on the choline scan. Much easier to see here as an area of hyperintensity, high cellularity on the diffusion scan, clearly not visible on the CT scan, and really a little asymmetric but difficult to pick up on the choline PET scans. So what do the guidelines say? Well, the guidelines seem to concentrate on detection, and particularly at initial imaging, and you can see almost every one of the guidelines still recommend the bone scans. You can see that we are beginning to change. So here, for example, are the EUA 2015 guidelines, and you can see that PET scans and whole body MRI scans are beginning to come in. But you can see the vast majority of them still concentrate on the initial staging of prostate cancer. We are beginning to see new guidelines emerging in other spaces. So, for example, when you're suspecting biochemical recurrence post radiotherapy or post prostatectomy, these guidelines still concentrate and recommend CT scans and bone scans, but newer guidelines are now beginning to suggest the introduction of newer imaging modalities. And so, for example, the Prostate Cancer Working Group 3 guidelines still recommends CT scans and bone scans in the response assessment setting, whereas the METRADS P guideline, which will be published in 2016, is now beginning to recommend whole body MRI scans for this purpose. So it looks as though things are changing. Now, in the response assessment setting, the whole body MRI scan or the choline PET scan should be used at baseline and after every 2 cycles in clinical trials, and after every 3 cycles in clinical practice, particularly for patients who have oligosecretory disease. So here is a patient that we've done multiple whole body MRI scans over many years, beginning in 2010, and we can see that his PSA levels are elevated, but clearly he has oligosecretory disease given the tumor load that he has, and he has had all these scans with all of these treatments. You can see he's received docetaxel, carbazitaxel, abiraterone, multiple treatments, and has been asymptomatic throughout, but his entire titration of his disease has been undertaken using whole body MRI scans because he has oligosecretory disease. This is what he looks like now. Unfortunately, you can see he's now symptomatic in August 2015, having failed radium therapy. So the idea behind using functional imaging techniques is that we want to move away in the response assessment paradigm from what we used to do before, which is use bone scans and CT scans, where you could only really talk about progression and no progression, to the new, more modern methods of evaluating bone disease, which are also combined with other things such as CTCs, PSA values, etc., etc. But this time you can see that bone disease can be broken up into 3 categories. So previously we could only ever say progression, no progression. Now with bone disease and the new imaging modalities, we can begin to look at response, stable, and progression. And clearly these will have a different impact on how oncologists think about their treatments and how they use them, with, I suspect, some economic impacts as well. So finally, in terms of the whole body MRI scan, we are beginning to see new standards for whole body MRI scans. Clearly there needs to be standardization of these new modalities, and the METRADS P classification system has been devised for whole body MRI scans in advanced prostate cancer. Though clearly it has not been proven completely to alter patients' management, and it will need to be trialed, but these trials are now beginning, and we can hope to see some developments in this area in years to come. Finally, I'd like to leave you with the last slide, which essentially summarizes CT scans, whole body MRI scans, and bone scans. We really haven't talked about sodium fluoride PET scans or newer traces such as choline PET scans, PSMA, FDHT, etc., which will be covered in a later lecture. So I'm going to leave this summary slide for you for a few minutes, and thank you very much for listening to this lecture, and hopefully you gain some insight into where we are going with imaging in metastatic prostate cancer. Thank you very much.